WCCS 101.1 FM and AM 1160. He is Dr. Dan Clark joining us this morning as we continue to mark Colorectal Cancer Awareness Month. Our conversation with Dr. Clark brought to you by Marcus & Mack, voted best personal injury law firm in the Best of Indiana County contest. Marcus & Mack, a law firm representing injured people. He is wearing his, underneath that blazer, that snazzy blazer, he's wearing his Pitt Panther shirt in celebration of Pitt winning, and you were at IUP last night for their game.
Yes, unfortunately, I was there. I may have been the bad luck charm there.
Couldn't bring home the win last night for the Crimson Hawks, but at least the Panthers are still rolling. That's good news. All right, not good news is something you were just sharing with me a couple of moments ago about colorectal cancer and the increased risk of it for certain individuals, and how we're somehow not even finding out if we're not asking the right questions, I guess would be the best way to put that.
Right. 70% are what we call sporadic cases, where there's no family history or anything like that, and the colon cancer pops up in you from polyps, and, that's probably environmental. And like we talked about before, that we've decreased the age for first screening to 45 because we're seeing increasing colorectal cancers in young people. Mm-hmm. But up to 30% come from either a familial history of colon cancer or a genetic risk for colon cancer. And statistics that I was surprised by in my readings getting prepared for this interview is that more than 50% of individuals are not asked in their doctor's office or their PCP, whether it's a nurse practitioner or PA or a physician, about their colorectal cancer history in their family. Mm-hmm. And, considering it's the third most common cancer in this country, that was a shocking statistic to me.
Yeah, absolutely. Let's talk about the two categories you just mentioned. First, genetics, mm-hmm. and the determination that you might be genetically disposed to colorectal cancer. Tell me about that, because I know that's been a really big interest of yours lately.
Right. As you know, I do the genetic screening for both breast and colorectal cancer, and it is a side interest of mine that I have a lot of interest in and have done a lot of research in. And, 10% of colorectal cancers have a true genetic link where it's actually inherited from your family. And if you have one family member with a history of colorectal cancer, that increases your risk almost twofold over the general population. And you should really be screened. And it's actually the criteria for genetic screening in colorectal is easier than for breast cancer, because it's been found that one family member with colorectal cancer increases your risk of carrying a genetic mutation that could lead to colorectal cancer.
Yeah, and it generally doesn't skip generations. If it's a risk for one generation, it is for the next, and on and on and on.
Right. It is a higher transmission that way, and mm-hmm. so it can miss generations, but it does have a rather significant hit rate, for each generation.
Yeah. So family history is certainly something that we need to pay attention to, and probably a lot of people just generally don't know what their family history is, so they need to ask questions within their own families.
It's not something we sit around the dining room table and talk about. You know? So, and in this day and age, because we can do so much prevention and earlier screening, 45 is the recommended age for people with average risk. Those who have a familial disposition, not genetics, and maybe they've been tested and they don't carry a genetic mutation, but 25% of people who get colorectal cancer have a familial disposition to colorectal cancer. In other words, they don't carry a gene for it, but because their family history, they have a significant increased risk. Mm-hmm. So in those people, we recommend screening at age 40 or 10 years younger than the youngest person in the family. So if a family member had colon cancer in their 40s, you should get a colonoscopy in your 30s, And if somebody had cancer in their 30s, which we're seeing now, you should probably get screened in your 20s, and so on.
So genetics, you were talking about the fact that, a family history and a genetic link aren't necessarily the same thing.
Right. We have known genetic syndromes that cause colorectal cancer. The most common or known one is called Lynch syndrome. It's a non-polyposis hereditary colorectal cancer, HNPCC. And so with that, you don't form polyps, you just form cancer. And that's the most commonly known. There's other ones that are familial adenomatous polyposis that can be inherited. There's some more rare syndromes called Peutz-Jeghers or Cowden syndromes, and some other ones that are polyposis related. In other words, they form from polyps and turn into cancer, but they have a higher rate of developing cancer. Anybody with inflammatory bowel disease, such as ulcerative colitis, has a higher risk of developing colon cancer as well. But the non-familial one, or the non-inherited ones, can account, like I said, for 25%. Nowadays, we can look, if you have a colon cancer, it's not just we say, oh yeah, you have a colon cancer. We look at it microscopically on the molecular level. And there's these things called antigens that are exposed on the surface of cells, or proteins, and they're expressions of your genes. And there's 4 different antigens that are normally expressed on colon cells. And the names aren't that important, the MSH and PSH and things like that, MLH. And if they're mismatched, in other words, a couple of them aren't expressed, that increases your risk that you may have a genetic predisposition to colon cancer, and you should have genetic testing done. So even if it's a sporadic cancer, and the pathologist, we check for this routinely on cancer cells, and the pathologist picks up that you have a mismatch repair, it's called, because those are the repair genes for the colon cells. And if you don't have those expressed, which you may be missing those genes, or those genes mutated, then we recommend genetic testing to see if you carry a mismatch or a mutation in one of those genes.
Okay, so if genetically you find out that you have an increased risk of colon cancer, what happens then? We determine, okay, you have it because we've done the genetic testing and we see that you're disposed to it. Now we check for it, we find out you do have it, or we find out you don't have it or don't have it yet. Mm-hmm. What are the steps?
Well, it changes our screening recommendations, and depending on what mutation, unfortunately with Lynch syndrome, that comes with a lot of other risk factors for other cancers. Just like we've picked up with the breast cancer gene, the BRCA gene, so-called because the breast cancer link was the first established, and we know that now there's pancreatic, ovarian, melanoma, prostate cancer also linked to the BRCA mutation. If you have the Lynch mutation, there are even more cancers linked to that. And so we do a much more aggressive screening. There's pancreatic, there's skin cancers, there's all kinds of different cancers on the Lynch syndrome. And so we do a much more aggressive screening because, as Dr. Ramanini talked about last week, if we pick these cancers up early, we have a much better result. 90%, greater than 90% for survival if we have a stage 1 colon cancer. Mm-hmm. So it's customized based on your own family history and these results, but much earlier screening is basically what we do.
Yeah, we should also delineate between male and female here. There really is no delineation, is there?
No, male tend to have a higher risk, but not by much, and so there's not a real big difference between men and women with colorectal cancer. It's the number 3 cancer in both men and women.
Yeah, and it's very deadly unless, as Dr. Ramanini said, as you have said, as Dr. Billen has said in his visits with us, and I think he's coming next week or the week after, it's the stage at which you catch it that is, or it is detected, is a better way to put it. It's that stage that is really going to determine how you approach its treatment, right?
Right. And if you have a family history, you should really seek treatment earlier, because people with family history of colon cancer also tend to have a more aggressive colon cancer as well. Mm-hmm. The younger people that we see with colon cancer tend to have a more aggressive colon cancer. So if you do have that family history, really should seek out early screening and genetic testing for it.
Okay. Treatment options with colorectal cancer. I imagine that there's a variety of those as well, both surgical and non-surgical.
Correct. Yeah. Of course, the number 1 treatment is getting it before it's a cancer.
Sure.
Doing the colonoscopy, finding the polyp, removing the polyp when it's precancerous. Then you don't need surgery or anything else. And so, but now, the number 1 treatment for colon cancer before it's spread is surgery. But we do a workup before surgery to make sure it hasn't spread. It's not infallible, but we do CT scans and things like that to make sure there's no spread. The colorectal drainage is directly to the liver, and that's why that liver is the #1 site for spread of colon cancer. And if it's in your liver, that's a stage 4, and so surgery is not going to cure that, so that at that point, we often do either isolated resection of those lesions in the liver, depending on how many there are and where they're located. But oftentimes that's preceded by chemotherapy to shrink them down. And then you get a combined laparoscopic or minimally invasive liver resection with the colon cancer resection at the same time.
Colorectal cancer is something that we try our best to raise awareness of in this month. We should think of it all the time, though. And one of the things about it, and I'm sort of picking up on this, but you're the expert on it, so you tell me. You have colorectal cancer somewhere detected within you, and depending upon the stage, again, how aggressively does it move to other parts of your body?
In general, it's not as aggressive. It takes a while for it to spread, and that's why it's important to get screened. Because if we can get in there, and as you know, I do the robotic colorectal surgery, as do my partners. If we can get in there and take the cancer out before it's spread, better than 90% survival, and you're in the hospital a couple days now with the robotics technique, because the bowels don't shut down after robotics like they do with open surgery. The recovery's faster even than laparoscopic, the old traditional minimally invasive surgery, which I did for many years before robotics. With robotics, you're home sometimes the day after surgery I've had. My average length of stay is 2 days. But yeah, with the robotics, we get it out of there. And if we get it out before the lymph nodes are involved, you may not need any further treatment whatsoever.
And how is survival rate determined? How is it measured? Is it by years? And by what measure is that?
Yeah, with all cancers, it was decided a long time ago by others that, we look at 5 and 10-year survivals, because it takes about that long to get significant data in anything. So we look at everything at 5-year survivals as the initial. And your survival is based on stage. So stage 1 cancer is it's just in the polyp. Stage 2 is that it's extended into the colon wall, but is not to the lymph nodes or anywhere else. Stage 3 is in the lymph nodes, and a stage 4 is it's spread beyond to other organs, such as the most common are liver and lung.
Got to get the screening done. Got to get the screening done, don't you?
Yeah, absolutely. That's the best way. It's a preventable cancer.
Yeah.
And so if you have the screening done, you can go in and get a colonoscopy. They remove the polyp. You're done. You don't need me. You don't need surgery.
Yeah. And we should start with primary care physician or go directly to someone in your line of work?
Depends on your insurance. As far as the screening, some insurances still do require referral. Usually it's either a surgeon or colorectal or a gastroenterologist who do the colonoscopies. And so most of them are done by the gastroenterologists. So however you need, usually referred by your PCP to have that done.
Yeah. Dr. Billen is with us next week, and then 2 weeks from now, you're back with us.
I'm back again to wrap it up.
Very good. Very good. Thanks so much for coming in today.
Pleasure to be here.
He is Dr. Dan Clark visiting us here this morning on the Voice of Indiana County, WCCS 101.1 FM and AM 1160. CBS Sports Minute next with Boomer. It's brought to you by S&T Bank.